Hey everyone, welcome to my Day in the Life series here on White Coats and Corgis. Most of you probably know me from Instagram or TikTok, where I make helpful free content for pre-meds and talk about my journey as a first-generation medical student. My mission here on YouTube is to give pre-med students all the information they need for a career in medicine. So in order to do that, I've teamed up with MedSchoolCoach to create this series where I'm going to do a deep dive on each medical specialty. And I want to start off by saying that it can be really difficult to accumulate the number of shadowing hours you really need to be accepted into medical school. And especially nowadays, this can be really challenging. A lot of physicians aren't open to shadowing opportunities in person the way that they were before. So that is why MedSchoolCoach decided to collaborate with over 20 doctors to give you a behind-the-scenes look at practically every specialty that you might be interested in. And this is all completely free. You can go to shadowing.medschoolcoach.com, register for the program, and then you get to choose whichever specialties you're interested in to shadow. At the end, you can fill out a short quiz, and then they'll give you a certificate of completion. That way you can count these hours on your medical school application.
So this is just a little bit about me. My name is Emily Singer. I'm an MD. I'm a general surgery resident, fourth year at The Ohio State University in Columbus, Ohio. I got my MD from the David Geffen School of Medicine at the University of California at LA. I was also a member of the Executive Admissions Committee for medical school. I got my BA from Stanford University with dual majors in Russian and economics. And I'm a med school coach advisor. Very importantly, this is me with a large tumor that I resected from somebody's thoracic cavity. There's a piece of diaphragm on there. There's part of lung. I'm wearing loupes, which are, they're special glasses that have magnifying glasses on the end, and there's a light. This is also me. This is with my favorite transplant surgeon and my favorite transplant surgery fellow. We were doing a living donor nephrectomy, meaning we were taking a kidney out of someone who was alive and healthy to give it to a relative of hers who needed a kidney transplant. So this is what happy looks like on general surgery. More philosophical. This is kind of how I think about how you should approach your life and your career, particularly if you're thinking about a life in medicine. So your life in 5 parts, in my opinion, can be divided as follows: family, friends, fitness, career, and sleep. Of those 5 things, you get to be good at 3. Once you have selected a career in medicine or in a medical field, and you decide to go to medical school to become a DO or MD, your medical career can again be divided into 5 parts: the disease processes that you treat, the patient population that you treat, your day-to-day life, the colleagues with whom you work, and your lifestyle. I'm here to tell you why surgery is so much better than everything else, in my opinion, based on my own values and personality. Surgery, you treat very acute disease processes, appendicitis, trauma, necrotizing enterocolitis, and so you're saving lives in a very acute setting. You also treat more chronic diseases, such as inflammatory bowel disease, like Crohn's disease, reflux disease, gallstone disease, kidney failure. So you improve lives and you form long-term relationships with patients. You treat benign diseases like obesity and hernias. So you improve people's quality of lives while also increasing longevity. You also treat malignant diseases like cancer, pancreatic cancer, liver metastases, so you can cure or palliate cancer. And again, this is like the way of dividing up your life in medicine in 5 ways. Next. Oh. Okay, your patient population can be anywhere from a fetus. Sometimes we operate on babies that aren't born yet, to people over 100 years old. On a day-to-day basis, you have a huge variety. You're in clinic, you're in the trauma bay, you're in the operating room, you're on the wards, you're in multidisciplinary tumor board, you're in the endoscopy suite. Your colleagues are going to be highly driven, very type A, and they have a dedication to excellence. Lifestyle, I'm going to be honest, you work long hours, but you have excellent compensation for that. And for me, you also have just a tremendous sense of reward in what you do. So my day as a general surgery resident starts as follows. I work out in the morning starting around 3:30 or 4 a.m. and I drink coffee. That's me working out, and that's what my coffee looks like. I then go into the hospital and we start rounding around 6 a.m. So what does rounding mean? It means seeing the patients who are admitted to the hospital after an operation or who are admitted with a surgical problem. There's a variety of services for surgery. You have acute care surgery, trauma surgery, colorectal, minimally invasive bariatric, thoracic, cardiac, vascular, transplant, hepatopancreatic biliary surgery, surgical oncology, pediatrics, and surgical ICU. So huge variety, tons of services. We rotate through all of those. After I see my patients between about 6 and 7 a.m., I go to the operating room. In the operating room, I might see people who are going to have small same-day procedures, meaning they come into the hospital and go home, people who have a need for emergent operation, people who come in, say, with a cancer diagnosis and have a scheduled operation, and some more complex operations, which are going to have multiple surgical teams and might even have like intraoperative radiation. I'm going to do open cases, which means big cuts, laparoscopic surgery. Sorry, those are my dogs. Laparoscopic surgery, which is with a camera through small poke holes, robotic surgery, endoscopy, and some bedside procedures. One of my favorite surgeons at UCLA had a playlist called Seize the Pancreas. There was a lot of Justin Bieber on there, I'm gonna be honest. But otherwise, I'm a big fan of Pandora's Hip Hop Barbecue if I'm operating on traumas overnight. I like hipster barbecue, a little more chill, good for endocrine surgery. It just depends on the mood and who I'm operating with. Otherwise, 90s alternative is always a good choice, or summer jams of the 2000s. During the day, I'll be seeing consults. These are patients that the surgical teams get called about. They're either admitted to the hospital for a different reason, or they're patients who are coming into the emergency department with a surgical problem. I might be in clinic seeing patients after they've had an operation, or patients who come back after a surgery. I only go to clinic about 1 day a week on average. And then there's tons of time for research and education. So every week we have dedicated time for education. This includes skills and simulation training. We might be doing trauma simulations. We might be doing robotic surgery, practicing our laparoscopic and endoscopic skills. We might be operating on a cadaver or a live pig. And sometimes we do off-site training. This battery's running low. We also go to national and local conferences where we present. And in my program, we have dedicated 1 to 2 years of research time during residency, which is separate from our clinical responsibility. So it's literally 1 to 2 years dedicated solely to research, during which we can pursue a master's or PhD. This is what a pig lab looks like. This is a pig who's under general anesthesia with a breathing tube in, and it looks like they're just setting up and haven't started an operation, but we actually operate on live pigs and practice skills before doing them on humans. Personally, I have time for hobbies. I think most residents, no matter what you do, will have things that keep them sane outside of the hospital. For me, I like to go rock climbing, I like to hike, I cook every night. I like to food prep for the week. I have 2 dogs. Sorry, they were barking. And yeah, I like to explore the city I live in, which is Columbus, Ohio. So this is in the emergency department. We have a 17-year-old woman who presents with abdominal pain. She's coming in with about 12 hours of pain. It started around her belly button or the umbilicus, and it's now kind of just stuck in her right lower quadrant, sort of like the right lower belly. She's also having some fever, some nausea and vomiting. She said that she had a little bit of diarrhea and feels like she has to pee all the time. She doesn't have any history of any medical issues. She's not taking medications. She's never had surgery before. She has a fever of 102 and a white blood cell count, which is a marker of infection, of 18,000. You examine her. Her exam, she's very tender to palpation, which means touch, in the right lower quadrant of her abdomen. So she got a CT scan, because our patients get CT scans when they come to the emergency department with belly pain, and it shows acute appendicitis. And we'll go over that in a second. The patient is taken urgently to the OR for a laparoscopic appendectomy, and she's discharged home pain-free the next day. So here's kind of the sequence of events in picture format. So she wakes up, maybe the pain wakes her from sleep. She's having severe belly pain. She is in so much pain, she goes to the emergency department. We get a blood test, which tells us what our white blood cell count is. She also gets a urine pregnancy test. Very good. You have to rule out any pregnancy. And then she gets a CT scan. So oftentimes it takes a long time for the CT scan to get read by the radiologist. So as a surgeon or a surgery resident, you have to know how to read the CT scan yourself. So these are 2 views of the CT scan, which is essentially a high resolution X-ray. Here's a very inflamed appendix, and here's another view of it. This is kind of, looks more normal. These are the hips, and this is kind of cut across this way. It's called an axial view. And both of these kind of show this very inflamed appendix, and this little thing in here, that's called an appendiculus. It's a little, essentially it's a little stool ball that's blocking the lumen of the appendix and causing the appendicitis. So then they call surgery, and this is what happens when they call surgery. The surgeons march in. So we then take the patient to the operating room. This is kind of somewhat what a setup looks like for a laparoscopic procedure. There's 2 surgeons, and they're doing surgery watching a screen, and they just have these long chopstick-like instruments that are going into these ports into the belly. And they're doing everything kind of looking through a camera and looking at the screen. This is what it looks like on the patient. These are the ports for an appendectomy. This is where the camera goes. This is the belly button. The patient's head is up at the top here. This is right above kind of the hairline down by the pubic hairs, and this is on the left side of the belly. At the end of the procedure, you just have these tiny little incisions, and the patient wakes up essentially pain-free, minus a little soreness from surgery, with just tiny little scars that are going to heal beautifully. We learn a lot of laparoscopic surgery and minimally invasive surgery because that's becoming the standard of care for so much of what we do. The days of like huge open surgeries, they're not over because there's certain things that we have to do, big cuts down the middle, but as much as possible, we want this 17-year-old woman to be able to go about her life as normal, without a lot of pain from a big incision, without a lot of cosmetic change to her body from a big scar. And so these are all the things we think about when we offer a patient surgery. And I think that's important, as part of our training. So we first what's called insufflate, or we blow the belly up with carbon dioxide. And that gives us space to see what's going on, because in somebody with such a sort of flat abdomen, there's no space unless you add air. So the air, or the carbon dioxide in this case, gives us space to see what's going on. We then put a camera in, which is this thing here. And then we put these two grasping instruments in. They're like literal grabbers. And we can pick up the appendix. And the appendix, if in somebody with acute appendicitis, is going to be very red, very inflamed. It's going to bleed easily as you grab it. So, you know, you can kind of elevate it with the grasper. You then cut its blood supply, and then you actually cut the organ itself at the base, which is on the first part of the colon, and then you take it out of the body. So people who have acute appendicitis, the standard of care is to actually remove their appendix, which isn't doing anything for them except for making them sick. And they'll never miss it. So that's acute appendicitis. That's the first case. There's two more cases. The next case is a 68-year-old man who comes to your clinic complaining of fatigue and weight loss. So this gentleman has a history of high blood pressure. He has type 2 diabetes, high cholesterol, and he's been smoking cigarettes most of his life. He comes to you with a year of progressive fatigue, 20 pounds of unintentional weight loss. So the first thing that comes to my mind in somebody who's 68, who smokes, is cancer, cancer, cancer. Especially fatigue and weight loss are like big tip-offs for cancer. So this gentleman is also anemic, meaning he has low blood counts. His hemoglobin is 7.1, and his fecal occult blood test is positive. So fecal occult blood test is just like a stool sample, and if there's blood in the stool, essentially, that test is positive. So this guy, he hasn't had a colonoscopy before, and actually a 68-year-old should have had a colonoscopy by now. The new recommendation is that you start routine colon cancer screening at age 45 with colonoscopy. And his exam, meaning his physical exam, is grossly normal. So as you look at him from head to toe, nothing sticks out as being abnormal. And you kind of do his whole exam, you look at his pupils, you look at his ears, you listen to his heart, lungs, feel his belly, feel all his lymph nodes, everything is negative. Nothing is coming out as being abnormal on his exam. However, you perform a colonoscopy and you find a rectal tumor. He then undergoes a CT of his chest, abdomen, and pelvis, and it turns out he actually has metastatic disease, meaning the cancer has spread from his rectum to his other organs. So he has multiple lung and liver nodules. You then talk about him at Multidisciplinary Tumor Board, which is a huge group consisting of medical oncology, radiology, radiation oncology, pathology, and in this case, colorectal surgery. And you kind of talk about him, you talk about his case, you review his imaging and his history, and you talk about the treatment plan for this gentleman. And so because he has a rectal cancer, the rectum being kind of the last portion of the colon before the anus, and you're concerned that he's actually going to not be able to pass stool through his rectum because of this cancer, which could potentially obstruct his rectum, you actually want to offer him a diverting colostomy so that he doesn't get obstructed, and then offer him definitive or palliative chemotherapy. So this is you performing the colonoscopy. And as a surgeon, you do a lot of these, particularly as a colorectal surgeon. And so in this case, your patient is awake but mildly sedated. Sometimes they're fully asleep, but this is sort of different than the normal OR where they're fully asleep, and you're looking at their colon. And in this gentleman's case, you see this. This is a tumor. This is a rectal cancer. And then you do an operation, and this is colostomy, which is sort of a diversion so that his stool, rather than coming out through his anus, actually comes out through this loop of colon, which comes to the skin upstream of his anus. And this will allow him to get chemotherapy. So this is a female, obviously. So in summary, general surgery offers perhaps the greatest variety of clinical settings, disease processes, patient populations, and acuity of any specialty within the field of medicine. It's a huge investment in your time, your life, and your sort of emotional and physical self. But in my opinion, it has the greatest reward of any specialty or any career in the world. And I think, takeaway is keep an open mind, and most importantly, keep a steady hand.